So I'm Olivia. Thank you all so much for being here. I want to give a big thanks to the BCCSU medical writing team for putting the slides together, pulling this presentation together. Um, so just a little bit about me, my background, I'm a family physician, and I did the enhanced skills year in addiction medicine. I work as an addiction medicine physician at St. Paul's, and I do family medicine and addiction medicine on the downtown east side and in corrections. Slides here. All right, so today we're going to talk about challenges and considerations when transitioning from community environments to other environments, inpatient corrections, bed-based treatment, and how we can best facilitate smooth transitions of care and good communication between all of these different care settings. So people with opioid use disorder experience lots of transitions in care, from community to corrections environments, bed-based treatment settings, and acute care settings. And there are potential risks of destabilization in all of these different transfers. Um, Transitioning from an inpatient, very structured, sometimes very supportive environment into community where things are a little bit less structured can be a real stressor for anybody. And that can result in destabilization from a number of different perspectives. Firstly, substance use. So returning to your regular environment can increase cravings. Secondly, sociostructural challenges can also present. So depending on how long you've been out of the community, you might have lost housing, or your housing might be significantly disrupted. You might have lost your financial means to support yourself during that time. So these are all major stressors that can culminate in return or increase in substance use. And the main concern in this transition period is that while someone is outside of their regular community environment, if they're not using opioids at all or using less, then they may have lost tolerance during that time. And that puts them at high risk of fatal and non-fatal overdose when they return to use or return to previous levels of use. So it's really important that we try to make these transitions as smooth as possible and also optimize care when they are outside of the community environment to reduce these risks, reduce things like loss of tolerance and interruptions in their OAT care. So people with opioid use disorder are at increased risk of a whole host of physical and mental health conditions. We know that they're at increased risk of hospitalization and emergency department use. So people who use unregulated substances are 5 times more likely to use the emergency department and 7 times more likely to be hospitalized. When we look at people who presented to the emergency department with a drug-related overdose, their 12-month mortality is 3.5 times higher than the general population. In 2017, among people who had opioid overdoses, 70% of them visited an emergency department in the year prior to that overdose. So what this tells us is these are really important touch points to engage people in care, to maintain the care that they're already getting if they're already engaged in care, and reduce interruptions. And really, we need to pay attention to these really important acute care experiences people are having. That being said, acute care isn't often utilized to its maximum potential, and often quite the opposite. People with substance use disorders often fear stigma and judgment when they present to acute care because they've had that happen to them in the past. And as a result, they may not even want to present to hospital. Often patients, don't want to come to hospital until they're on death's doorstep. And that can make uh, treating the situation much more challenging because they are in so much pain. And if people are hesitant to give appropriate opioid doses, then that can just kind of perpetuate things. They'd be wary of hospital staff. They may fear being judged, and that can have a cascade of effects. So one potential sort of sequelae of that is they may be um, more hesitant to provide history about their substance use, and also they may be uncomfortable asking for things like PRN medication. Sometimes patients will say if they ask for PRNs, they feel like that they're being seen as drug seeking, and then that turns them off from asking, and that leads to their pain and withdrawal being undertreated, which we want to avoid. So there are lots of things that we can do to reduce stigma and discrimination in our own practice, and also to change the practice of the people around us. So the first is offering harm reduction services, supplies, and education. And this is a really important strategy for building therapeutic inroads with patients. So I find that it often helps demonstrate to the patient that, I'm willing to work with them, whatever their goal is. If their goal is ongoing use, that's totally fine with me. I want to help keep you safe, um, while you're using. So talking about things like rotating their injection sites, helping them find veins, talking about, using test doses, using with other people, making sure you provide Narcan. All those things are part of patient-centered care and making sure that we're meeting patients where they're at. It's important for us as providers to participate in self-reflection, notice our own biases, our own judgments, and then take steps to address that. Whether that's doing your own reading or attending things like cultural safety training is really important in optimizing the care that we provide, and just owning that everyone has some kind of bias. It's not anything wrong with that. It's just what we do about it that matters. Um, we want to remove our preconceived assumptions about patients, so that's sort of part of that. And then using respectful, non-judgmental, and non-stigmatizing language is sort of where all this starts. So some examples of things that we want to language we want to use that can help um, reduce stigma in the care that we provide and in our documentation are using person first language and medically appropriate language. So instead of saying things like addict, junkie, injection drug user, we want person first language, so person who uses drugs, person who injects drugs. Um, Opioid addiction, opioid abuse, those aren't terms in the DSM. That doesn't actually like really mean anything. What you're trying to say is the diagnosis of opioid use disorder, which is a more appropriate way to describe um, those previous terms. Denies and admits are really common in medical language, denies chest pain, things like that. And in that context, it's probably fine. But in a substance use context, because there is so much stigma, writing something like denies alcohol use implies that the patient is using it but isn't telling you. So it's better to just say they report no use. That's just more accurate about what happened. In terms of referring to clean and dirty, either in terms of state of use, like abstinence versus not, or the result of like a urine drug screen, for example, we want to, again, like use more medically appropriate language. So if someone is not currently using substances, they're abstinent rather than clean, because it implies that if they are using, that they're dirty, which we don't want to do. And same thing with the urine. The urine is positive for fentanyl, not dirty or like hot. When we look at terms like illegal or illicit, um, technically those are accurate, but there's a negative connotation with them. So unregulated is the preferred term. And problematic is better defined as saying something like high risk, because problematic is just sort of non-specific. And we want to sort of talk about like what is it that we're actually trying to get at when we're um, describing things or documenting. And the way that we speak to patients and write things down is really important because it demonstrates how we're thinking and how we're viewing the patient. And that's really influential in how our colleagues also view the patient and how they perpetuate that documentation. So it really does matter in shifting things like culture and changing people's hearts and minds about these issues like stigma. So when we look at the acute care side, there are a few sort of common scenarios that might happen when you're receiving someone into care with opioid use disorder. So the first is someone's already on opioid agonist therapy or OAT prior to hospitalization, and we need to continue that while they're hospitalized. So a few key tips here, making sure you cancel that community script while they're admitted to avoid accidental double dosing, and then making sure that you send that discharge script when they leave so that you have no interruptions in their care from when they transition from community into acute care and then back into community again. Second situation, you might have someone who presented not on opioid agonist therapy, but that was started in acute care. So firstly, good job for you in acute care for starting this life-saving medication. But we want to make sure that we have a good discharge plan so that their OAT can be continued after discharge. And the last situation you may encounter is someone who doesn't want any treatment for their opioid use disorder while in hospital, but they're interested in initiating OAT on follow-up. And always what we want to do in this situation is reduce barriers to accessing OAT or any addictions care. So things that can be helpful are providing scripts in hand. So if patients are kind of in this situation, often I'll give them like a prescription for a Suboxone microinjection blister pack. The scripts are only good for a few days. So I say, you know what, just fill the script and you can just keep it with you. Because if the mood strikes to start your microinjection and it's Sunday at 10 o'clock, I don't want the script to have lapsed or the pharmacy to be closed. I want to reduce all of those barriers as much as possible so that when the patient decides it's the right time, everything is lined up for them as much as we can. If someone is not on OAT and not really interested in it during their admission, we want to frequently revisit offering OAT to them during the admission and engage them in motivational interviewing. So it's really important to discuss the patient's goals because OAT is compatible whatever your goal is for your substance use. If your goal is abstinence, if it's reduction in use, if it's ongoing use at the same levels, all the kinds of OAT are still relevant. And it might also help us tailor the best therapy for you. So, for example, Suboxone is an awesome medication, but if someone wants to still feel still use substances and like feel them, then Suboxone might not be the best choice for you because it might blunt those effects. But another OAT option is probably better. So those are things that we can help guide patients in selecting the right kind of oat for them. And that's going to increase their chances of actually staying on it and benefiting from it. Um, Part of our counseling with that is discussing the benefits of oat. So obviously oat reduces fatal and non-fatal overdose, which is huge. Sometimes patients aren't really that concerned about that. You know, they haven't had overdoses. They don't really perceive themselves at risk of that. But talking about things that do matter to them, like reducing their cravings and withdrawal, because if they're on a long-acting opioid, they won't wake up feeling in as much withdrawal every morning. So that can also be an important thing to discuss with patients that may sort of put it in terms that make it relevant for them or their goals. And if at all possible, we want to try and start out in hospital if the person expresses interest. Because again, we want to reduce those barriers. You want to have them have that first dose while they're in hospital so that they can sort of see what it's like, ask you questions. There's a bit more support there. So the first time they're trying it isn't when they're, you know, in the community, but that's still okay too if that's what works. If you need any help with doing this, like if you don't have that much experience with OAT, but the patient is saying that they want to try it in hospital and it's appropriate, then you can always consult the BCCSU 24/7 line or the RACE app for assistance. Because again, like if that's the right time, we want to strike while the iron's hot. So when someone's in acute care, managing their withdrawal and their pain are paramount. So there are lots of different ways to do this. If we're managing someone's withdrawal symptoms, opioid agonist therapy is obviously great for that. Whether it be methadone, Cadian, Suboxone, whatever it is, and offering top-up doses, titrating the dose while they're in hospital. Short-acting opioids are also really effective and going to be necessary for most patients in treating certainly their pain and sometimes their withdrawal as well. You can use non-opioid adjunct medications, but generally we want to treat opioid withdrawal with opioids. Firstly, because that is the treatment. And secondly, because when someone is in acute care or any non-community environment, they're at risk of loss of tolerance, like we talked about. So providing a non-opioid adjunct medication is not going to help maintain that person's tolerance, but providing an opioid medication will. And that's an important part of keeping patients safe when they transition back to community, is maintaining their tolerance while they're out of the community. When we're treating patients' pain, it's really important to remember that baseline OAT isn't adequate for pain management. We can do some kind of tricks to, you know, optimize how OAT can manage pain and maybe contribute, but it's not sufficient alone. So someone will need short-acting opioids to manage their pain, just like anyone else would if they have a painful condition. Important things to note, though, important nuances for people with opioid use disorder is firstly, they have higher sensitivity to pain. The second thing is they have higher opioid tolerance. So all in all, that means they're going to need higher doses of opioids, usually more frequently. And it's important that when we are selecting opioid doses, like short-acting opioids for patients with opioid use disorder, that we find the appropriate dose. So often there's concern with too high dose without really consideration being given to the harms of too low dose. Because under treating people's pain and withdrawal, is a big cause of patient-initiated discharge, return or increase of unregulated opioid use, and also just like human suffering. So picking the right dose, not too high, not too low, is really important in providing appropriate care for people with opioid use disorder. So when we're making plans in acute care, we want to develop plans in collaboration with the community provider. They're going to be the ones that are going to continue this plan. So it's really good to have them on board, so you know that whatever plan that you're making with the patient as an inpatient is going to be continued. And also they can provide really valuable collateral about, things that have been tried in the past and haven't worked, or barriers to previous plans, that you can maybe help problem solve with more resources in the hospital. We always want to be transparent in our decision making with patients. So this is important for building trust, but it's also important for having patients be on a treatment that is going to work for them and that they're going to feel good about. So that involves, talking to patients about, does this oat require daily witnessed ingestion, or can they, get carries right from the bat? Is this one where you can earn carries or not? And is that sort of at provider discretion? How long are you expecting them to be on this medication? Obviously, that can range, but giving people a ballpark can help them go into opioid agonist therapy, making an informed decision. And then we can also help problem solve with patients about what barriers they perceive in continuing on with this plan. Obviously, making the plan is an important part, but things change. So we want to check in with patients frequently, make sure that we're still on the right track. They're the captain of the ship. They tell us where we're going. We just help them get there. So we want to know, are we still on course? Um, we want to make sure not only that patients are doing informed decision making, but also the person receiving care. So we want them to know, what we're thinking, what we want them to do in the community. One example that comes to mind is sort of having someone in the community inherit a benzotaper that you don't actually tell them about when you're starting it in acute care. So that is not ideal. We want them to know, what our rationale is, and also what things they need in order to feel comfortable with that plan. So if someone wants to do their benzotaper with daily dispensed medication, probably don't discharge them with a weekly dispense script, because that's going to set up tension that first time they see their community provider. So being all on the same page is really important, so everyone is informed about what's happening and in agreement with the plan. And we want to provide support to improve people's access to care. And that may vary depending on your treatment location. So often that's things like having a pharmacy with good hours, maybe having a delivery pharmacy if that's like an option in your area and a barrier to your patient accessing their care. Maybe it's, providing cab vouchers or bus tickets. Outreach teams, if your area have them, are so critical in helping patients remain engaged in care. They can help patients get to appointments, get to their pharmacy, just be an extra support person. So engaging the interdisciplinary team in supporting patients is so important, in really setting our patients up for success when they're transitioned into the community. Um, a big part of discharge planning is providing a warm handoff, and that involves a few different things. So firstly, we want to consolidate doses that are started in hospital to once daily. So it's just a nice dose that can be given in community. We want to provide discharge prescriptions. Usually longer prescriptions are better. I always provide a month long script when patients are discharged from hospital. Obviously, we want people to see their family doctor within a week of discharge, but that doesn't always happen. And transition to community from hospital can be a very overwhelming time. So I don't want my script to be part of what's adding to that chaos. I want that to be out of their mind so they can just get their dose and live their life. And then when they have time to see their doctor, they can prioritize that based on, their own decision making. We want to provide a discharge summary to the community provider about when did they get their last dose, what happened with their doses in hospital, and anything that we want them to follow up on. If the person is not yet connected with a community OAT provider, providing that referral is really important, and making sure the patient knows where they're supposed to go, when they're supposed to go there, what the hours are of the clinic, and making sure it's a good fit. If the person has to take a half day off work every day or every week to go to their OAT provider, that's probably not going to improve their function and help them, maintain continuity with that clinic. So finding the right fit is really important. And we want to offer people information about community resources. So if that's harm reduction services, social services, whatever it may be in their area based on that person's unique needs. We talked about outreach support services are so important. If you have access to them, I would highly recommend utilizing them. Um, Provide a take-home naloxone kit. It's good if your hospital has these to provide them at bedside. We don't always know when discharges are going to happen. So if you kind of wait until discharge to provide the naloxone kit, you're missing an opportunity to provide this life-saving antidote. So it's always good, when someone comes into hospital, I right away order it to the bedside, so I don't have to think about it at the time of discharge. Um, if someone is receiving the care, even outside of the medical provider, um, we want to maybe provide handover to them as well. And the patient would be the best person to kind of advise on that. If there's, staff at their housing that they feel like are an important part of their care team, then looping them in can be important if the patient's on board with that. And then also providing very clear instructions to your patient, and potentially to the receiving provider about what your plan is. So if you're starting a microreduction in hospital, but it's going to be continued in the community, providing instructions, maybe written instructions if that's appropriate for the patient, about what you want them to actually do. Take this medication twice a day, for X number of days, is really important in helping make sure that plan comes to fruition. In terms of the actual success of um, translating this information to community, we're kind of so-so. So a survey in Canada showed that 25% of community providers did not get a discharge summary when their patients were discharged from hospital, which is not ideal. But there are things that you can do as the community provider. You can always call the inpatient team, even if it's not the person who saw your patient, to find out, what do I need to know? What happened in hospital? When was their last dose of oat, and what was that dose? Those are all totally appropriate things to ask, and things that you need to know in order to care for this person going forward. Also, depending on maybe how organized they were on the inpatient side, you may have to do some additional steps. So things like Plan G, so that their OAT is actually covered. If they don't have ID and that wasn't arranged or started in hospital, physical description forms can be really important, so that the pharmacy is able to actually dispense the medication to the patient. So looking at all of those other social barriers or structural barriers are really important in making that transition to community successful. And sometimes, if they're already seeing you in community, that ends up falling on your shoulders, unfortunately. Um, in hospital, changes to OAT are really common, and opioid agonist treatment doses that are given in hospital don't show up on PharmaNet. So that's really important to know. It doesn't mean the person hasn't had it; it just doesn't show up. Doses are often adjusted or split if someone is unwell or there are other indications for splitting their opioid agonist therapy. It may temporarily have been replaced. So if someone has QTC prolongation or an acute kidney injury, we may rotate to something else for that acute period and then put them back either on that original form of oat or something um, more appropriate based on their current medical status. Hopefully that would have been discussed with you if you're the person taking over their care, but just kind of a window into how things might happen with someone's oat while they're admitted. Um, in the acute period after discharge, it is important to have frequent follow-up with patients. They might need their dose adjusted. So if they, increase their unregulated use after discharge, they may need a little bit more oat, depending on what their situation is. The titration may have progressed while they were an inpatient, but not be done. So still finding that dose may be part of your role there in that follow-up period. And people may also have acute pain after leaving acute care. That might depend on the reason for admission, but if they just had a surgery, making sure that you're assessing for that and addressing that is important. Obviously, untreated pain is a big trigger for use, so we want to make sure that we're doing our best to treat patients' pain. Um, Harm reduction counseling, like we've already kind of alluded to, is so important in this period after people leave the inpatient environment. So people have loss of tolerance because they're using less or not at all when they're out of the community. And that loss of tolerance puts them at very high risk of overdose death. So when we look at literature after release from things like corrections or bed-based treatment, the first 2 weeks after release, the overdose risk and the risk of death is very high. So ideally, the inpatient team would be providing that harm reduction counseling. But if they don't, when you're receiving that patient in the community, it's important to do that, to talk about strategies to reduce their overdose risk, but also let them know, like, this is a really high risk time. So just be really aware. Is so important. Um, if someone has returned to unregulated use after their admission to acute care, Like we said, you might want to adjust their oat dose. If prescribing safer supply is part of your practice, you may want to consider that if that's appropriate for the patient. Um, and making sure that everyone has access to harm reduction supplies and services.
Oh, Olivia,
Yeah.
are we able to wrap up so we can move on to the case
Yeah,
presentation?
definitely. Um, okay, I think we can skip this. And this is a summary. We're done. Here are some resources.